Sir, we are live now. With all your permission, I am starting this session for today. Good evening, everyone present here. I am Faraz from IJCP Group. Welcome all the participants on today's session. Let's welcome today's speaker with great honor, Dr. Lohit Reddy, sir. And let me share some of the achievement of sir. Sir has done MBBS, DNB in radiology, radiation oncology, FESMO, trained in IMRT, IGRT, SRS, SBRT, and proton and carbon ion therapy, and head of radiation oncology research at HCG Hospital. And today, sir is going to discuss on a topic breakthrough radiation oncology, advances in the era of precision oncology. By taking not much time, I would like to invite sir to know more about this topic. Over to you, sir. Kindly proceed from. Sir, your voice is low, sir. Like you, I can't hear you. Try to mute and unmute, sir. Hello. No, sir, you are not audible, sir. At the initial time you were, but right now, sir, you are not audible. I think there is some technical issue and sir is having audio issue. Once it's fixed, we will begin his presentation. Sir, you are still not audible. Sir, you try to rejoin, sir. Like try to rejoin once.
Hello, hello,
Yes,
hello.
sir. Yes, sir. Now you are audible. Now you are audible, sir. You can
Okay.
proceed.
So my topic for today is going to be in this divided into this three main divisions. One is advances in technology, advances with respect to imaging, and what is the latest research which is happening in oncology and the breakthroughs which we have been involved and we are incorporating it into a regular practice at HCG. So I think the holy grail of radiation oncology, it forms one of the main pillars for oncology treatment. And it is used as a main modality of treatment in at least around 80% of the patients, either in curative setting or in symptomatic management, like for example hemostatic radiation. There is also pain relief, which happens very significantly with respect to radiation. So the most important thing when we give radiation is to improve the therapeutic ratio. So the focus is on optimum tumor control with least amount of normal tissue complications. So probably if you see a decade ago, the main problem with cancer management used to be the toxicity. People used to be scared about toxicity. So now with advent of technology, with advent of targeted treatment, with advent of precision oncology, the focus is not just on tumor control, it also is on improving the quality of life and ensuring that the normal tissue complications are at the least. And with this, over a longer period of time, it's all about value-based medicine, wherein the cost spent by patient over a longer period of time is also a lot lesser. And since cancer itself is becoming a chronic disease, I think it's absolutely important to also take care of the financial aspects of the patients, and hence the overall quality of life patient is maintained in an appropriate manner. So I think with respect to computational technology, with respect to imaging technology, uh, radiation oncologists have, taken a deep interest with respect to usage of imaging, and we have inculcated it into a regular practice. If you see in the 1950s and 60s, it used to be just drawing on the patients and using, X-rays, which used to be a very advanced, kind of a modality back then. But now with a lot of PET-CT scans, MRI scans, CT scans being involved in a planning process, there's always a chance of knowing where the actual tumor is and also where the critical structures adjacent the tumor is, and we can protect those critical structures, and our focus will be mainly on the tumor tissue and reducing the normal complications. I think with eye computational technology, we are going more into proton, carbon ion, with imaging technology, and ultimate aim is to give maximum cure and reduce as much side effects as possible. And now we usually mainly use Linux, and in India, Cobalt is being obsolete. So only a few centers use Cobalt, but I think those will also be phased out in the next decade to come. And mainly we use very advanced linear accelerators with high computational technology to give precision treatments to our patients. So if you see, this is how we used to treat patients, very, primitive. Just use X-rays, just draw it on the patient's body, and we just used to deliver. So the toxicity used to be huge. So you can see the skin reactions, it used to be extremely toxic. So, tolerating these treatments is going to be very, very difficult. But now we have moved on from conventional RT to at least a basic IMRT, wherein you can see on your right, the conventional RT is mainly involving, if you're treating a pelvic case, you can see the dose to the bowel, the dose to the rectum, sigmoid, the dose to the bones is very, very significant. The pelvis and the bone marrow toxicity could be very significant. Just below you, if you see the toxicity to the critical structures like parotid, the spinal cord, the minor salivary glands, the mandible, it's getting extreme amount of dose. But with advanced technology, you can see the you know finite sparing of these critical structures, so that the radiation is very focused to the intended area and with least amount of side effects. And below slide, you can see the parotids are spared. So the risk of xerostomias, the spinal cord toxicity is going to be less. The myelopathy is going to be a lot lesser. And the mandibular toxicity or the risk of osteorenal necrosis, if we exceed a certain dose, is going to be significantly lower with this, advanced technology. So these are some of our patients. If you see, stage 3 and stage 4 are not death sentences to patients. Even with stage 3 and 4, patients tend to live longer right now. It's become like a chronic disease. And over the next few decades, with advent of targeted therapy, immunotherapy, I think we will find that a lot of patients will live longer, probably a few decades, even with cancer. Cancer is not a death sentence. So patients have very good quality of life with very advanced technologies right now, targeted therapies. And you can see this is one of our patients wherein he went to another hospital. He told he has very few months to live, and now it has almost been, this is 2017 scan, but now it is 2024, and patient is still living good without any quality of life issues, and leading his normal routine. So this is one of our case, nasopharyngeal cancer. Again, a very advanced case with neck nodal deposits. And after a combination of radiation plus chemotherapy, patient is doing well even after around 6 years. So other great impact what has happened with oncology is the usage of molecular imaging. Molecular imaging is, we use multiple molecules tagged with radioisotopes for exactly mapping the tumor burden before starting any treatment. So this helps oncologists to stage the disease as well. So here you can see the lymph nodes which have lit up like bulb, wherein you can see actual disease burden, and this helps us in also tracking the treatment domains, and helps the radiation oncologist to exactly focus on this tumor. And also with the CT scan incorporated into the molecular imaging, we can also see the normal structures, the liver, the bowel, the critical structures are joining, and we can exactly eliminate those areas and focus our treatment on the intended area. The other thing is MRI. We always try to incorporate MR into our planning processes, mainly for brain, prostate, for pancreas, and in head and neck cancers, wherein you can see there is a lot of difference between the CT scan, which is on the right, on the left, and on the right you can see the MRI, very eloquent mapping of the tumor in the laryngeal region. So this is one of our flagship linear accelerators. So here you can see one of our linear accelerators wherein there is a CT scan incorporated into the machine. This is called tomotherapy. So with this, it's a very standard machine for image guided radiation. Usually radiation is given over a period of 33 days to 35 days in a radical setting, and in a symptomatic setting it's usually given in 10 days. So prior to starting radiation, we tend to do a imaging to exactly map the disease. That is at the stage of starting radiation. And on a daily basis in tomotherapy, we usually do a verification CT to see if the intended treatment is going to the correct area. So here you can see the lung tumor, and we are exactly matching the verification with the planning CT, whether the CT is correctly sitting on the intended area, and if there is any variation with respect to daily imaging. If at all there's any variation, we can just try to do offline adaptation, and we try to deliver the radiation to the intended area. So the advantage with tomotherapy is it has an MVCT. So you can see with the KVCT, there's going to be a lot of artifacts with respect to dental implants. If you're treating an adenic case, or if there's bubble, there's a lot of artifacts. But by using MVCT, you can see though the accuracy is not that good, artifacts are a lot lesser, and it will be very appropriate for image guided radiation. And as I told you, this is about offline adaptation during the course of the treatment. If the patient's weight is reduced, or if there are any changes with respect to the treatment casting, or if the movement of patient is too much, or if there's good shrinkage of the tumor, or if there's movement of normal structures during the course of the treatment, then it's always good to use the offline adaptation. Over a period of time, we can try to like adapt to the changes, and hence adapt to whatever challenges the tumor or the normal structures are posing to the delivery of the treatment, and that can be adapted and appropriate treatment can be delivered. So what are the other ways how we reduce toxicity? If you see, there are a lot of patients with brain metastasis, either from the breast, lung, colon, renal cell carcinomas, etc. So, it could be hematogenic spread. And when we treat brain metastasis, the main important problem was cognitive deficiencies or memory problems when we treat the whole brain radiation. So now what we have evolved is the hippocampal sparing. Hippocampus is an area where memory is maintained. So once we start sparing the hippocampus, the cognitive deficiencies isn't going to be there for patients, because patients tend to live very longer now. And we have seen patients living for 3 years, 4 years without any significant deterioration of the quality of life with respect to cognition. So, as I told you, radiation used to be treated for 30 to 35 days. And now with breast cancer, we follow the UK and the Canadian protocol, wherein the 30 to 35 days treatment is being coned down to 19 days, giving the same amount of dose, which was given in 33 days to 19 days. You can see the skin reactions are a lot lesser, the cardiac dose is a lot lesser, the cardiac complications have been almost similar to the 30 to 33 days. And also, the toxicity with respect to the lung is also on the lower side. And hence, we have, treated around 3,000 patients with this protocol, and one of the highest volumes in India. So this was again one of my colleague, Dr. Kritika, who has, tried to work on brachytherapy. It forms one of the very important component in carcinoma cervix. So after external beam radiation, we give brachytherapy, which is an internal treatment to eliminate the residual disease if at all there is anything present. And with stage 3B, 3C, 3C1, 3C2, now it is, we had excellent results of around 98% at our center. So until now, I was speaking about Torchlight, which is the conventional linear accelerator, but now I'll be speaking about pencil, accuracy beam, which is called CyberKnife. CyberKnife is a cuckoo robot, which is a robotic radiosurgery machine. So instead of giving treatment for focal lesions over a period of 35 days, we can complete the treatment within 5 days. 3 to 5 days. This is called a stereotactic radiosurgery or radiotherapy. So you can see on the left, the traditional LINAC will give a lot of dose. You can see the surrounding normal structures are going to be extremely irradiated. Whereas on the right, you can see the CyberKnife, very pinpoint, multiple beamlets, extremely focused, and you can see the sparing of the brainstem. So the toxicity is a lot lesser. So the mechanism is also different. It's mainly vascular mediated. It destroys the blood supply to the tumor cell, and it also creates a very, very high immune impact, wherein there's going to be release of a lot of new antigens, and hence our body's immune system is able to pick up cancers and probably better elimination of the tumor. And with immunotherapy coming into the mainstream cancer treatment, a combination of CyberKnife and immunotherapy has been very, very effective at present. So what are all the malignancies which can be treated, or benign conditions which can be treated with CyberKnife? These are the most common cancers: pituitary adenomas, both secretory and non-secretory. Even if it is secretory, we try to, do the prolactin level, sorry, growth factor levels, vasopressin, oxytocin. We evaluate which hormone is oversecreting, And after CyberKnife, we again map it, and there's going to be significant release, and it could be converted to non-secretory, and we may put them on drug therapies to, also like supplement them if at all there is any deficiency of the hormone. So one other one is arteriovenous malformations. We try to like map the nidus of the arteriovenous malformation. We try to give radiation in around 1 to 3 sittings, and with this, the risk of bleeding is going to be a lot lesser. So again, this is also called suicidal disease, trigeminal neuralgia along the trigeminal nerve innervation. There's going to be excruciating amount of pain like an electric shock. And by giving one fraction of radiation, there's going to be very significant pain relief within a few hours, and in some patients in the next few days. So this is, it became really famous once Salman Khan got the treatment done in US, New York with gamma knife. But CyberKnife is more robotic. It is available in India, so you don't have to go abroad to get treatments. So everything is possible in India. Okay, and even the human resource with respect to doctors, everything is possible with India. So even after recurrence, after treating the standard line of treatment, if at all there's any recurrence, you can, use CyberKnife. You can see a nasopharyngeal tumor or sinonasal tumor, which has come back after, treatment. And now there is, uh, after CyberKnife, there's no disease whatsoever. So now the buzzword across the world is artificial intelligence. So if you see, we have incorporated very well with respect to radiation, and there is a new concept of online adaptation, very quick planning. Usually the planning used to take around a day for the physicist to plan and decide the beams, the decision for using the appropriate plan by the radiation oncologist, and to approve the plans would take a lot of time. But now it is very dynamic, it is very quick, and with use of artificial intelligence, we can decide on multiple plans at a single setting, and the treatment can be decided over 5 to 10 minutes, so that appropriate plan can be used for that appropriate day. If at all there are any changes, those changes can be adapted dynamically. I was talking about offline and tomotherapy, but with ethos it is going to be online and dynamic. So this is how we plan. So you can see very focused treatment on a daily basis, how we adapt to the changes, and this is what has created a great impact with our patients. So you can see there is, this is just one, adaptation what we do. You can see on your left, the traditional IGRT, IMRT with tomotherapy, you have to give such big margins. But with the online adaptation, you can see the volume is a lot lesser. The red line is a treatment area, wherein the bowel, can be easily spared, and very focused treatment to the intended area. So this is one of our patients. You can see the changes, the multiple colors, and the shrinking tumor volume, meaning the tumor over a course of the treatment, how much it is shrinking and how we have adapted to the changes. So this is the latest and the new concept. So wherein abscopal and radscopal effect, meaning when we give, if a patient has a lung cancer and if he has metastasis in the bone and the liver, just by focusing on the lung cancer, by treating the lung cancer, there is going to be signaling pathways which is going to be activated, and that can automatically shrink the liver tumors and the bone metastasis. So this is called abscopal. Radscopal is if adjacent lesions are not treated, but because of the signaling pathways, that can be shrunk. That is called radscopal. And this is a very huge, impactful treatment strategy in the era of immunotherapy. And this is one of our models which was created by my colleague, Dr. Kritika, wherein we developed our own cell cycle to use appropriate, tumor agnostic, uh, sensitizers for immunogenic cell death. So this is mainly using dendritic cells and to eliminate the myelodysplastic cells, and all the T cells can be activated by appropriate usage in the cell cycle. So this is one of our patients, melanomas, which are considered to be very immune sensitive. And this patient came to us with bleeding. We tried to give radiation to stop bleeding, but then we also incorporated immunotherapy in this patient. And you can see the bleeding was completely stopped with very good regression of the tumor as well. Hepatocellular carcinomas usually, they are mostly viral induced, FB, FC, FA. So you can see a combination of immunotherapy and radiation. You can see, which was not possible probably a few years ago. to control hepatocellular carcinomas, which are considered to be a death sentence. And even with portal vein thrombosis, it has been a very, very good regression of the tumor. This was a farmer's son, nasopharyngeal cancer, again, told nothing to do in stage 4. He came back after a standard treatment had failed, and now with huge lymph nodes across the body and solitary bone metastasis in D8 vertebra. And you can see after a combination of immunotherapy and radiation, there is a very, very good regression of the tumor. So this is again a lung cancer, again a patient with multiple metastasis. You can see radiation given at one site with shrinkage uh, of the site in the other part of the lung without actually treating with the radiation in the other part of the lung. So you can see the liver metastasis. As I was talking, you can see on the left the studded liver metastasis after a combination of radiation plus immunotherapy using cyberknife and nivolumab. You can see excellent responses in the liver lesions. So now coming into the latest concept of FAPI, fibroblast activated protein inhibitor. Now we are in the era of theranostics, wherein injectable radioisotopes can get deposited tagged with proteins of specific cancers, and they can get deposited and deliver very high dose of radiation. This is one of our vice presidents from Congo. He went to US. He got treated, with standard lines of treatment, but failed. Came to India in an air ambulance with on a stretcher, severe amount of pain, unable to bear. We explained to him about the newer treatment modalities which is available for prostate cancer. So we did a PSMA based, actinium based treatment, and by around 6th day after FAPI therapy, you can see the regression of the lesions in the bone. Excellent responses. PSA dropped significantly, and the side effects of treatment is as minimal as possible with excellent pain relief. And now it's almost been 5 years, and patient is continuing his public life. Again, an ovarian cancer, struggling with ascites. Just a single combination of platinum-based chemotherapy with FAPI, and you can see excellent responses with this combination of treatment. So we are also a research, we are one of the very few private organizations who do a lot of research. So we also just not follow the West. I think we have data. Head and neck cancer is our disease. It's more common in India. So we try to make and evaluate if we can develop our own solutions and not mimicking the West. And our main focus is adaptive research, wherein we see how we can evaluate based on our recurrence pattern in the retrospective studies. And one of my colleague, Dr. Kritika, has come up with a risk stratification for tongue cancers, and our treatment decisions in the tongue cancer which come to my clinic is based on this risk stratification and not based on the Western data. And we have prospectively started collecting data, and based on the same concept, we have written a textbook chapter at one of the Harvard publications. So this is how we also, it's not just, it's very easy for doctors to say that, okay, fine, if a patient comes back with a recurrence, it's just blaming it on a biology of disease is very easy. But, it's also important to know why the recurrence has happened, evaluate what are the outcomes of each individual doctor, and we try to analyze how we can improve our outcomes with respect to cancer. It's a learning curve, and this is the recurrence pattern analysis, which we conduct at HCG, and we do a 2-yearly conference wherein we evaluate why certain patients recur and which are the aggressive cancers, what is the modality of mutations, and we're getting into genomic based medicines wherein we exactly map the genomic pattern of a certain disease to prevent recurrences. And this is the way to go. So we also work with a lot of tech companies now. A lot of tech companies come and approach us to develop multiple protocols. And here we found out a tumor and stromal radiation dose. This was mainly done in rectal cancers, wherein if the tumor stromal ratio is on the higher side, that means the responses are very, very minimal. And this was a grant which we got from Siemens, and we worked and developed this protocol. So this is the other concept what we're developing. This is about the diet. If you see, in olden times, we used to have our rishis. We used to, eat only once a day. If you see, the cancer cells mainly depend on glucose metabolism. The energy generation is mainly by glucose. That is by anaerobic glycolysis, and the glucose acts as the main substrate. Now we are into a process. A lot of people would have done intermittent fasting, but a certain way of intermittent fasting and maintaining the sugars less than 90 and supplementing that with the mainstream treatment can prevent cancer in a very effective way, and trying to prevent the cancer recurrences, because you're modulating the food supply to the tumor cells, you're starving the cancer cells, and that can help in reducing uh, the chances of recurrences. And we are working closely with American College at Boston, where we are trying to develop protocols on the same. So metabolomics, again, on the same concept, it's not just genome, transcriptome, and proteome. We feel cancer is mainly caused by the energy powerhouse of the cell, which is mitochondria, and we're trying to see if any metabolites can be mapped, probably create a biomarker, and try to see if we can develop some drugs related to certain metabolites. So this is again the same thing, mitochondrial analysis, and it's all about interaction between reactive oxygen species and how it can, create a damage to the DNA of the cancer cell, leading to cancer. So this project, again, we developed with IIT, Indian Institute of Science, wherein if a patient walks into my clinic with a PET-CT scan, can I predict what are the chances of a patient coming back with a disease within a 3-year period time? So we developed a predictive modeling using artificial intelligence, machine learning protocol, and we tried to develop two imaging biomarkers just by an image, very similar to a blood biomarker like PSA, CEA, CA19-9. We developed CN19 and extend with an accuracy of around 93% and specificity of around 87% to exactly predict the chances of local recurrences in oral cancers. So this was again based on an MRI, again the same kind of a concept called radiomics and radiogenomics, wherein we're also trying to map the local recurrences of oral cancers using MRI. So this is one more grant from the government, wherein we are trying to develop federated learning, trying to create decision support systems in cancer, very similar to IBM Watson, which was trying to incorporate a lot of data from the US. But this is very customized to the Indian population. We can just stratify head and neck cancers ranging from oral cavities, oropharynx, hypopharynx, and exactly predict which factors impact appropriate treatment decisions, risk stratifications, and the outcomes of the patients, with also the side effect mapping of patients. So radiation has always been logistics-based, treatment. Now we are getting into genomics-based treatment. We are trying to personalize radiation based on a certain, genomics. Like for example, if HPV is positive in oropharyngeal cancer, the responses are much better. You don't have to go to the standard dose of 35 days. Probably you can reduce it to 30 days. So this customization is absolutely important. The medical oncology has evolved into complete transition into the targeted treatment domain and the personalized space. But now we radiation oncologists are also moving into that space and trying to customize treatment, personalized treatment based on the genomics, proteomics, metabolomics patterns. So these are some of our publications, okay, some of our standard international publications. And with this, I conclude the future starts today and not tomorrow. Thank you. Hello? Hello? Am I audible?
Thank you so much, sir, for taking out your valuable time and sharing your knowledge on this topic, sir. As it is very important topic which need to be discussed, I hope that the insight, the knowledge which you have shared will be very much helpful to all the doctors who have joined this session. Sir, we have received some question from the participants, sir. If you allow with all your permission, shall we take these questions?
Please, please. Yeah.
Yeah, the first question is from Dr. Agarwal. He's asking, what are the ethical consideration using novel and potential expensive precision oncology treatment in radiation therapy?
And see, this is all the standard treatment. So the reason for getting these machines is only after an FDA clearance and only after clinical trials. So these are, established treatment strategies. So there's going to be no ethical concerns with this. These are established treatment. We cannot give treatments which are not approved, which have not been evaluated in randomized controlled trials. So these are all standard protocols what we follow in oncology management.
Thank you so much, sir, for sharing your insight. Moving forward, we have another question from Dr. Subramaniam. He's asking, what strategies do you use to monitor and manage the side effects of advanced radiation therapies?
So I think what we do is if a patient is getting treatment over a period of 7 weeks, we tell the patient to come and review with us on a 3-day basis or a weekly basis based on the area which we're treating. For example, when you treat head and neck cancer patient, there could be a lot of swallowing difficulties or there could be a lot of mouth ulcers. So we have to dynamically start giving drugs prophylactically to reduce the risk of patients having complications with respect to radiation. So we tell them a lot of mouth garglings. We give them some mouth gel so that there's not much of ulcers, and we tell them some basic exercises so that there's no long-term fibrosis. So these are all some of the precautions what we take. And by doing all these proactive measures, the side effect profiles, both short-term as well as long-term, will be on the lower side.
Thank you so much, sir, once again for sharing your experience on this question, sir. Moving, we will be taking one last question from Dr. Supriya, and she's asking how have recent technological advancement in the radiation therapy improved patients' outcomes? What's your views on that, sir?
I think it's leapfrogged into the next era. We have used computational technology to the best. We know which areas are being correctly treated, okay, where we can spare the critical structures. So obviously, if you see compared to a decade ago, if it was probably around 10%, now it is almost like 95%. There's still a 5% improvement which is needed to even better our technology. There's still a lot of scope for improvement, but we are almost there, and we use a lot of artificial intelligence in our planning. We exactly know which area is being treated dynamically during the course of the treatment. And with usage of this technology, the side effect profile is also on a lot lower side. So comparing to a decade ago to now, it is way, 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 way advanced.
Thank you so much, sir. I hope that Dr. Supriya has received his answer. Sir, as I can see, sir, there is no more question from the participants, sir. As there is no more question, sir, shall we conclude this session with all your permission?
Thank you. Thank you so much for the invitation. Okay,
Yes,
best
sir.
wishes. Thanks for the patience.
Welcome, sir.
Thank you.
Sir, it's really great to have you, and we would like to see you in future also in different topic. Till then,
Thank
take
you.
care of yourself,
Thank you.
sir.
Thank you.
Thank you so much.